we still read the number of people who die, due to floods, etc. Heat as well, and these are, the acute events. So the people who are being impacted by the slow climate change events actually are much less well documented. Now, this graph basically shows you the kind of impacts both on health and health systems, starting from the very bottom. When you see what are the ecological determinants of health, we talked about the extreme weather, the habitat loss, soil loss, water shortage, global temperature rise, and sea level rise. This, of course, impacts on the social and structural determinants of health, like housing, livelihood, reduced equity, supply chain disruptions. And reduced equity, why? Because it's always people on the margins who are affected by any of these shocks. Health systems are impacted, obviously, because you have patients crowding in hospitals when they get sick. A decline in air quality, indoor air quality impacts staff. Doctors and nurses also tend to get sick, when there is an event like this, or they can't get to work, and damage to health infrastructure and supply chains. And finally, all this results in what we see in the patients, which is heat-related, or in the community, heat-related illness. Of course, there's a lot of anxiety, trauma, and post-traumatic stress, increase in asthma, COPD, infections like malaria, dengue, malnutrition, which is because of the food system's impact, and conflict and migration. Now, on many of these parameters we're going to talk about, India is actually very severely impacted. Our pollution ranking is extremely high. It's estimated that we lose about 5 years in life expectancy because the WHO standard is 5 micrograms per cubic meter of PM 2.5, and we are actually at an average of 58.7, which is way above even the national standard of 40. Now, we recently did some analyses looking at the impacts of climate change on health, particularly on women and children. And as part of that, we actually looked at data from different sources. So here you see the first graph on the left is from work that was done by our GIS lab, but taking data from CEEW, their vulnerability estimates. And you can see that 75% of Indian districts are at risk for extreme hydromet events, that's floods, cyclones, and droughts. In the middle graph, you see India divided up into its 20 agroecological zones. And we see, again, the relationship between heat waves, the dark red colors, particularly Rajasthan, Gujarat, Andhra Pradesh, Orissa, are at very high risk for heat, as also large parts of central India. And on the right side, we see the red colored part of this map is essentially the entire North India, which is at very high risk of air pollution. Now, of course, women and children are disproportionately impacted, as not unexpectedly, and a lot of that is because of the roles, responsibilities, and cultural norms. So not only are women and children more likely to die in a disaster, 14 times more likely according to UNDP, but also crop failures resulting in food insecurity and increased agricultural work, water scarcity, where women have to go out and collect water, conflicts, again, there's increased violence against women, lack of access to healthcare, fuel shortages, and we know a lot of rural women are still collecting biomass for fuel, and higher mortality of women and displacement. Similarly, when you look at children, obviously, whether it's air pollution, whether it's heat, floods, their schooling is disrupted, and the impacts of pollution have been seen as a huge increase in acute respiratory infections. Now, we know, of course, that a lot of our emerging and re-emerging infections are zoonotic. They come from animal sources, and there is a huge number of them around the world, which keep popping up from time to time. Some are very localized, some are more global, like dengue, and others like Nipah, Ebola, Zika, of course, then chikungunya, the hemorrhagic fevers, all of these. And then you also have things like scrub typhus, which is very common in India, probably underdiagnosed and underdetected, leptospirosis, plague, and anthrax, and of course malaria. So, so the chances of some of these infections increasing or new ones coming in are more likely now. Why? Because firstly, the weather patterns changing, the vectors are changing their behavior. They can survive in parts where they could not survive before, and you also there is a theoretical risk that microbes that have been frozen in the Arctic ice may actually be released when the Arctic ice melts. That's also being a warning that's been put out. And then, of course, with increasing urbanization and globalization and biodiversity loss, and constantly cutting forests in order to expand our own footprint, the chances of domestic animals, wild animals coming into contact, and humans and animals coming into contact is increasing day by day. Now, recently, there's a committee that was set up by Niti Aayog, and I was part of that to really come up with a kind of a framework, for India on pandemic preparedness. There's also One Health mission that I'll talk about in a minute. And we basically put our recommendations under 4 pillars. The first one looking at governance, legislation, finance, management, because in a large country, you need a structure where, there's a federal government, but also states being able to work very well together seamlessly. And we also, believe that we probably need a new Public Health Emergency Act and a new set of laws, because we are operating with a very ancient one at the moment. And the National Disaster Response and Management Agency really was the one managing COVID, but probably not ideally placed to manage a public health emergency. The second pillar is around how do you manage data? How do you collect data? How do you manage it? How do you share it? How do you analyze it? And how do you use it for early predictive warning, but also forecasting and modeling? This is both in the human as well as animal and environmental sectors. The third pillar is around, strengthening research, innovation, manufacturing, infrastructure, and capacity building around developing countermeasures. And the fourth one is around basically communities. How do you engage them? Risk communication and partnerships. Now, the government of India has also come out with a One Health mission, and essentially a One Health approach is basically, taking an approach of the fact that humans have to live in harmony with our environment and with other species. And well, the One Health mission, of course, has been driven by the principal scientific advisor to the government of India. And it has all of these ministries and departments that have to come together. And again, they're looking at pandemic preparedness in terms of both human and animal. How do we prevent and how do we prepare? Joint outbreak response, integrated disease surveillance, and strengthening routine prevention programs. So it's quite easy to say these words, integrated disease surveillance and a joint outbreak response. But I think we have not actually demonstrated on the ground how this might actually work, at a district or a sub-district a level. What does it actually mean? For example, we work in Koraput district in Orissa, and we regularly see both anthrax outbreaks, and there've even been deaths in the last year, a few deaths due to anthrax, and of course a number of other diseases, waterborne outbreaks and vector-borne outbreaks as well. And in the rural areas, of course, people live in close proximity with their animals, and so I think this becomes extremely important. And also their livelihoods depend on the animals and the animals' health. So if you have diseases that are going to impact them, then people are also going to be impacted, either directly, they may get a disease, or if you're going to cull them because there's an outbreak of avian flu among the chicken, for example, then that has a huge impact, especially on small farmers. So the One Health mission in India basically emphasizes surveillance, especially for the priority pathogens. These are those families of viruses which are most likely to cause epidemics and pandemics. There's a list that's being updated by the WHO now, about 30 priority pathogen families. And they've also, this concept of identifying a prototype virus within each family so that you can prepare, whether it's a vaccine or a diagnostic. You take a prototype and you get your scientists to work on it, and that hopefully enables you to respond much faster when you're actually faced with an outbreak. Of course, we also have the threat of antimicrobial resistance, and so that needs to be part of this whole approach, because again, it's linked to the use of antibiotics, for animals and for fish and things like that, which in turn increases the risk of AMR in humans. And you also need more R&D and innovation actually to come up with solutions for AMR. There's the whole issue of data, how to manage and analyze. And I think we saw during COVID that there were many gaps, in the way in which we collect and manage our data, and how representative it is, and how good the systems are across the different states, even something as basic as death and cause of death reporting. And then there's the R&D part covering the medical countermeasures. And of course, every report now talks about lessons from the pandemic. So there is a Center for One Health in the NCDC, and it has these 4 national health programs. There's also a Center for One Health, a whole institute actually coming up in Nagpur that's being jointly managed by the ICMR, the ICAR, as well as the Department for Science and Technology. So it's a good approach where different ministries have come together from the beginning to run an institute, and hopefully that means that there'll be much more collaborative work right from the very beginning. Now, just like I showed you at the beginning, some threats identified by the World Economic Forum. This was a list that we had prepared when I was still at WHO, sort of highlighting some of the health challenges that we are likely to face. Again, climate was actually number 1 over there. Conflicts and crisis. Again, we see around the world that, again, impacting usually the poor and women and children. Then equity and making healthcare fairer, gender equality, mental health, expanding access to medicines, infectious diseases, of course, preparing for epidemics. Then unsafe food and unhealthy diets also identified as one of the top risks. Adolescent health, public trust, harnessing new technologies, AMR and WASH. Now, the global burden of disease, if you look at their periodic updates, that they come out with, it's clear that over the period of the last 25 years or so, you've had, non-communicable diseases really increasing relative to communicable diseases, and cardiovascular diseases, cancers are the top killers globally. But what is more worrying is that both deaths and DALYs due to NCDs are increasing. I mean, the attributability due to dietary risks has been increasing, which is very worrying, because not only are more people today hungry and undernourished than they were 10 years ago, but also the type of food and the quality of food that people are getting are actually it's not healthy. And therefore, we know, for example, in India that only 10% of people are eating a diet which is consistent with what the NIN would, define as a nutritious diet. The INDIAB study, I'm sure everyone is familiar with it, which was sponsored by the ICMR and done over a period of 15 years, led by Dr. Mohan's group, but many groups around India showed that the prevalence of different NCDs was extremely high, particularly if you look at abdominal obesity. These are the absolute numbers, with 350 million people with obesity, 315 with hypertension, so on, and over 100 million with diabetes, and even more worrying, 136 million with pre-diabetes. If you look at diabetes prevalence over here, you can see that the states which are marked in red have over 10% prevalence in the adult population. And Uttar Pradesh was the only one which, had a less than 5% prevalence. Others were in the middle. If you look at pre-diabetes, then you'd see the opposite, which is that the states which had less diabetes actually have very high pre-diabetes, above 15%. So basically, it's a ticking time bomb. All of these are just waiting, to develop into full-blown diabetes unless something um, is done very rapidly. And all metabolic NCDs were more frequent in the urban rather than in the rural areas. But even rural areas, you can see that pre-diabetes is pretty high. So I think the issue really here around NCDs is, and the connection with climate is, I think, through the food system and the pathway. As we are dependent more and more on, basic cereals like rice or wheat, less on the greater diversity of diets that one used to have in the past, and a high sugar, high fat, and high salt processed foods. The Household Consumer Expenditure Survey showed that 10% of the household income, both in urban and rural areas, now is going to buying the processed or ready-to-eat foods. So that's a significant amount, and it's often higher than what people spend on buying and cooking fresh food. And that is actually a key driver of this kind of increase in NCDs. And so we really need to start thinking around policies around agriculture and how our agricultural system needs to change to become much more nutrition sensitive, as well as climate sensitive, of course, but also about our PDS, our school meals, etc., and how can we actually start providing ensuring that people have access to a much healthier diet. So I want to end with some points from a recent scoping study that we did for the Ministry of Women and Child Development, a report on the impacts of climate change on women and children, focus on health, but also on livelihood and education. And I'll just run you through some of the recommendations. The report is now on our website, and I can send a link to those who are interested. We try to actually look at all available data from India. We had several rounds of consultations. Thresia and some of you were part of it. We met NGOs from all parts of India. We also met with government officials who write the state action plans. And what we realize is that while most states do have climate change action plans, they don't really think about these issues of women, children, gender, etc. And so what we've suggested is that not only do you need a state action plan, it needs to have a budgetary allocation. It needs to be coordinated at the highest level. It needs to have monitoring evaluation. We also have found that there were big gaps in data. And so we need many more longitudinal studies that look at people living in different agroecological zones and collect primary data on the lived experience of these communities. Pregnant women, particularly with heat, there is now enough data to show that they're at higher risk for preeclampsia, for prematurity, for other adverse outcomes. So we definitely need to have training for our frontline health workers on how to manage some of these climate-related risks, particularly like this one. Pollution and heat are both huge risks for pregnant women, but also the definition of the heat wave that needs to be modified, because we know now that the wet bulb temperatures are very important for health. It's not just the absolute peak daytime temperatures, but the night temperatures, the humidity, and so on. Then diseases, we know that these vector-borne diseases, for example, they are expanding, and we need to make sure that, for example, the PMJY, the health and wellness centers, the whole Ayushman Bharat program actually takes these into consideration. There is a direct correlation in studies between natural disasters and gender-based violence, both in emergency shelters. But even more worryingly, we found that when you look at districts which are drought-prone, let's say over the last 10 years, you find that in those districts, the incidence of domestic violence, intimate partner violence, is significantly higher. So we, obviously that leads to recommendations of course, about gender clinics, hotlines, helplines, make sure that emergency shelters address these issues, but also we'll have to think about longer term solutions and solutions that involve men as well, because first reaction when they are faced with a lot of stress is to take it out on women. Biomass is still being used significantly in rural areas. That's accounting for a quarter of the ambient PM 2.5 air pollution. So I think a low-hanging fruit really is to ensure availability of clean cooking facilities. We've given everyone LPG connections, but we need to address the gaps in the implementation of the Ujjwala scheme, and particularly in poorly ventilated urban low-income housing and slums. The exposure to people who are indoors may be even worse than those who are outdoor. And then women as first responders, we know that most of our frontline health workers are women, and they also are impacted and they're also under stress. And so we need to look at how to address, strengthen our mental health program, and also support these our frontline workers. Partly we can use technology, of course, for early warning systems, for training, for digital support tools, and so on. But technology can only be a tool along with a good deal of human resources. And then finally, I think we have some findings on livelihoods, especially of rural agricultural women being threatened, and very limited research on the impacts of climate change on migrant women and children. So here we're saying, we do need a multifaceted approach. We have to look at water, very importantly, at diversifying livelihoods, looking at sustainable resource management. SHGs can play a major role, and so can panchayats, provided, of course, that they are empowered and that they have adequate resources given to them. And then we may need to look at different agroecological zones to see the needs. These zones, of course, cut across state boundaries, and that's why it's important, I think, for states to actually work together when they have similar problems and issues. And then on the data, there are big data gaps. A lot of data is not disaggregated by age and sex. We don't really have a gender-based budgeting. We're not able to get that kind of data from our departments and ministries. And we need more research. We've called for more research to understand the gendered impacts of climate change and to develop and test solutions. This is not to say that there are not other vulnerable groups like people with disabilities and the elderly and so on, who are also going to be and are being severely impacted by climate change. But this report focused on women and children, and that's why the recommendations address them more. So thank you very much. I'm going to stop sharing my screen, and I think we can go into the discussion part now.
Yeah.
Over to you, Tricia.
Yeah, thank you very much, Dr. Soumya, for the very insightful presentation. It brought out a lot of dimensions, clearly showing the intensity and also the multi-dimensions of the issue, the linkage between climate change and health. So again and again, we are so thankful to you. And now the floor is open for discussion. And the chat box says, I think, too, is it a question? I mean, Soumya, you can also check.
Yes. I'm having a look at that.
Yeah.
So the question about, do all states have climate action plans? Yes, they are required. There's a national action plan on climate change. There's also a national action plan on climate change and human health. And so not only do states are supposed to have a state action plan on climate change, but also climate change and health. And many states also have a heat action plan, and cities and districts are supposed to have heat action plans. So the plans are there. Very often you'll find the plans on the website. It's really an issue of who takes the ownership, how it's implemented, and most of them are not budgeted. So every department is supposed to do it with whatever budget they have, and that often means that the implementation is weak.
Yeah. And another one is a comment. Some regions contribute to climate change and more, but they cope with it better. Differential causes also need to be studied apart from differential impacts.
Okay, so we know that, the Western countries have contributed much more than countries like India or other Asian or African countries. We know historically that they have been responsible for maximum greenhouse gas emissions. The problem is that the impacts are being felt much more by developing countries, and therefore the adaptation needs to happen now. And most of the global discussion is on mitigation and carbon emission and reduction of that and carbon credits and all of that. Very little attention has been paid to adaptation. That's really the problem. So countries like India really need to step up action on the ground, but also I think bringing the global focus on adaptation. There's another question on, do you think we have reached a tipping point or a point of no return? I mean, I think, a lot of, there are these planetary boundaries that we are crossing. And of the 9 planetary boundaries, I think we're sort of the tipping point already on 4 or 5 of them. So the point is that, what do we mean when we say that, there's a point of no return? I mean, that we just can't give up. So the science shows that if you reduce the carbon emissions, CO2 emissions, greenhouse gas emissions, you can begin to actually reverse the global warming. It takes time. And so today, the trajectory beyond, we are still increasing. The temperatures are going up. But let's say 2030 is the time when we are supposed to reduce, which is not going to happen. But if it happens, it will take another 15, 20 years, but global warming will go down. So I think there is hope. We need to be optimistic. But everybody needs to act and act extremely urgently. And of course, some parts of the world need to do much more than other parts of the world. And that's a problem because they're not doing it. For us, I think the issue, also the first person, I think, who had asked the question about some people cope with it better. I think traditional ways of living, were more adapted to local climate, whether it was housing, whether it was food, all that has changed now. So our cities are certainly not designed for Indian weather. We design the cities based on some other model from outside. And so now we are seeing the effects, but we can still change that. We don't have to continue doing it. So we know that putting in green and blue spaces, for example, in cities, less concrete, more open spaces, ways of building, improving ventilation, all of that actually can reduce temperatures. And then there are things you can do to houses as well, including reflective paint and putting greenery on the roof, etc., which reduces temperatures significantly inside the house. So there are solutions. There needs to be a really concerted effort actually now. Then, of course, public transport is a big thing because we know that vehicular emissions is a major cause. And so in India, I think public transport in cities would be one of the biggest interventions we could do actually to reduce the impact, to reduce heating, reduce pollution. And also it's good for health because when you have public transport and people are using it, you tend to walk more. And that's also, of course, good for your own health. So it's a win-win.
Dr. Soumya, do we have research data on mental health and climate change, and 2, reproductive health of women and climate change?
Reproductive health, I told you about the impacts during pregnancy. That's what's been studied now, and there's more and more data coming out on that. I think on mental health, there is a recognition that climate. So again, it depends. You see, if you look at disasters, yes, there's quite a lot of data on post-traumatic stress and so on after disasters. But if you look at more long-term impacts or what we call the slow impacts, much less. And then things like, domestic violence and all that, which are already there, but may increase as a result of, for example, it's heat. It's been shown that when you have heat, prolonged heat wave, suicides go up. So those kind of associations are there. There's another one on wet bulb temperatures and humidity. It's been found that Southeast Asian countries and South Asian countries have better tolerance to humidity. Yeah, certainly there is, we get acclimatized. And therefore, we need India-centric studies regarding heat. Absolutely correct. And this is why now we are actually, many people are working now with IMD and others to have these better definitions. In India, areas with more dry heat in April and May have more heat-related illness and deaths. And this year, again, we saw that happening. But the records are still not they're not accurate, I should say. And so it's very hard to really give you a number. But a recent study that Purnima Prabhakaran and her colleagues did, they found excess mortality. They looked at, I think it was 10 cities, and they could find excess mortality related to the days where there was a higher temperature. So that kind of study shows you that this is happening. We had the famous Ahmedabad heat wave of 2010. So many people died, but since then, you don't find cities or states actually reporting the heat-related death. So that needs to improve as well.
Okay.
Studies related. Yeah, I think I've answered most of the questions in the chat.
Yeah, anybody else wants to ask questions? Please raise their hands, or even you can directly ask. And I think that climate change and health is a less debated and discussed area now. So
Yeah.
people are just getting knowledge only about that. So.
Hi, Dr. Swaminathan. If
Hi.
you don't mind, I have a question for you.
Yes.
You mentioned about how we, like in India, we have been focusing on climate adaptation, and I'm also wondering, in terms of the influencing policies with regards to the proximal causes of climate change. What is our level of influence as scientists involved in climate change related research and policy making from a healthcare standpoint? Do we also have influence on the proximal causes, say things that you mentioned about urban planning, construction, things like that? Or do you think we are at a point that we can only focus from a healthcare standpoint on adaptation rather than controlling the proximal causes?
So I think we have to be advocates for these other things. We don't have any direct control, of course. But I think as medical professionals, we have a responsibility to advocate for reducing the risk factors and the determinants of health. So I think to that extent, producing the data and throwing a light on these problems, and maybe even doing research on some solutions and showing what works, because unless you offer policymakers some solutions, it's very difficult to get them interested in the issue. So I think to that extent, yes, there is a big role, and that we could actually influence what happens.
And is also on a related note, from the healthcare sector standpoint, is there any efforts or measures with regards to decarbonization or trying to be carbon neutral, or is it where is India with regards to that?
So that's something WHO has been pushing quite a bit. India is beginning to look at that. I mean, I think you do have states that are, for example, using solar and energy. So I think there's an opportunity as these new health facilities are being built or remodeled, etc., to put in place renewable energy to make sure that we have 24/7 electricity and water and things like that. Safe disposal of of the bio waste, but it's still there is no consistent national policy, but I think it's happening. There's also funding available now from ADB and banks like that to move the health system in that direction. But I think the obvious one, of course, is solar energy and things like that. But much more important, I think, is supply chains and just looking at the carbon footprint. And I understand a few hospitals in the US have now started doing that. Again, it's very few, but really looking at where does your emission come from? What is your carbon footprint? Where can you reduce it? A lot of it comes from food, from supply chains, from plastic, from travel. These are the major sources of emissions. So I think that kind of awareness is probably not there. I don't think hospital administrators are thinking about it, but that's a direction in which we need to go.
Thank you.
Hi, ma'am. You talked that pollution and heat are big risks for pregnant women. So, could you just elaborate on that, or is it like it's there in urban or rural? There is a difference between urban and rural, or could you?
So we don't have that much of granular data, but I think there have been associations. So cohort studies, for example, that follow pregnant women have shown that those women who are exposed to higher temperatures have certain risks, like prematurity and higher incidence of preeclampsia and things like that. Similarly, the Air Pollution Association, again with prematurity, with smaller birth weights, and of course with respiratory morbidity has been shown, but air pollution we know now is associated with a host of other things. It's a pro-inflammatory, sets up a pro-inflammatory condition. So you get more diabetes, more cardiovascular disease, strokes, even dementia. And there is a significant loss of life expectancy. So we don't have monitoring stations all over the country, so it's very difficult. I think we have monitoring stations basically in cities, much less in rural areas. And generally people used to think that pollution is a problem of cities, but it is not true. So if you look at the Indo-Gangetic Plain, for example, the entire belt of North India is subject to a lot of air pollution. It gets worse in the winter, but really, throughout the year, the air quality is way above the WHO standards. There was also a recent study that showed that when you go above the WHO standard, which is 5, for every increment above that, you are seeing a health impact. Whereas India's cutoff is at 60. And so between WHO cutoff of 5 and the India cutoff of 60 actually is the zone in which you're seeing incremental impacts on health with increasing air pollution. So I don't think there's very few places in India which have good air quality. I don't think any place would actually fall under the WHO standard. But even the Indian standard, which is much more relaxed, is not met, by the majority of places. So it is a huge issue which is not well recognized, I think, by administrators, and it's not something there is a national air quality program, of course, and there's funding. I think there are 130 cities which have been funded, but progress has been very slow.
Thank you, ma'am.
Hello.
Yes.
So, I'm Jagadishan. My question is, to what extent the medical community is oriented to this climate change and its impact at different levels, not at the community level on epidemic, pandemics and all, or for in the case of NCD and all, for individual case management also, this is of much significance. So in general, medical community at different levels, to what extent they are oriented, what should be the action plan for addressing that? And there is another question also from my side. You very well point out the importance of intersectoral action at different levels, including the One Health Committee at national, state and all. To what extent this intersectoral action, even though the different departments come together and all, but mostly we have a culture of working in silos. So for that culture, we could not produce the desired result. So on these 2 points, what is your opinion and your suggestions?
Second point, I think you've answered it. So I think efforts have to be made actually to, that's why I said it's there, and now a big plan is there, a One Health mission is there, but we have to actually see how it gets implemented.